Hello, everyone. I am Dr. Chung Young-eun. For this case discussion, we have invited 3 doctors. Hello. Dr. Kim Kyung-won. So this is your first time to this case discussion. What's your impression? Dr. Chung Jong-chul was doing a very good job, and this is my first time to this discussion. I'll do my best. Thank you very much. Let's get started with the case discussion. We asked the dentist to write to us if they have encountered some challenging issues. Today, we'll talk about immediate placement case at the anterior region. The first case is about a 57-year-old male patient, and the chief complaint is number 22 mobility. The dentist wrote to us saying implant placement is planned after extracting an upper lateral tooth. What do I need to pay attention to? Looking at the X-ray in the picture, there is a periodontitis with a severe bone resorption, number 22. Compared to adjacent teeth, more bone resorption is observed. So what do you think about this case? Looking at that, number 21 and 22 have a perio problem and they look extruded, and the dentist planned to extract number 22 for implant placement. In my view, on the X-ray or in the picture, number 22 has severe mobility. So it is planned to be extracted, but at a glance, number 21 is not good as well. What will happen to 21? And it is also difficult to extract both of them. If you extract number 22 alone, perio treatment for number 21 is very important. If you are to extract just one, first I would like to hear from Dr. Yang, the perio specialist. First of all, I see so many patients with perio problems, and immediate placement is considered right now. In my view, perio treatment should be done first. I believe the dentist must have thought number 2's prognosis would not be very good. So he plans an immediate placement. In my case, when there is a perio problem, the predictability of immediate placement is very questionable. So even though you consider immediate placement, there are so many factors to be considered. Dr. Son Young-hee, Dr. Yang, specialized in periodontology, would do the perio treatment first, but I have a practice, and if the patient wants extraction, I would extract the tooth. And the immediate placement is considered by the dentist. When the perio problem exists, immediate placement after extraction, we need to consider the vertical height, very important factor. Not only the disadvantage, there is advantage. There's so much soft tissue. It is favorable for primary closure, and we need to think about so many things here. After careful consideration, whatever the approach, the treatment can be done. The dentist who raised this issue plans to do the immediate placement. Let's think about how we can do that. In my view, I did not major in periodontology, so I would extract number 22. There's just a standard X-ray and a clinical picture, so I don't have a definitive idea what's going on there. The adjacent tooth, number 21, looks severe bone resorption, So it would be difficult to control the depth. As Dr. Son said, I would prefer to place quite deeply. If you just think about the distal bone height of number 22, the relation with number 21 would not be very good. So we talked about this case at issue. So Professor Yang has prepared a similar case to present to us for easy explanation. Seeing patients, sometimes I feel very sorry for the patients. In this case, the perio problem is quite severe, and the patient is very afraid of getting the perio treatment, and the patient is very busy to make a living, and the situation has gotten worse as the patient delayed the treatment repeatedly. If you look at number 11 on panorama, radio opaque line is observed around the apex of number 11. This is a very bad case, and the treatment was continuously delayed. So it has gotten like this over 2 years. So the trimming timing is missed. The patient innocently asks for our treatment, but as we see it's a really challenging case. So in this case, immediate placement is considered. If you look at number 11, there is a recession and soft tissue is not very favorable. How can we restore the case? The patient is afraid of treatment, so we need to do a lot of treatment at the same time rather than waiting. I told the patient it would be a simple procedure, and I extracted and placed an implant, but the situation, including the perio situation, was not very good. So it was submerged rather than delivering the temporary. This is July 2018. The tooth was like floating in the air. In October, the tooth was extracted. If you look at the extracted tooth, calculus is covering all the way up to the apex. But I could get the stability from below, and the implant was placed at the desired place. As Dr. Son said, when perio is not good, soft tissue problem is resolved. When perio is not very good, I use a lot of granulation tissue. After securing sufficient granulation tissue, implant is placed. The granulation tissue at the top portion is used to close it. Provisional is used for temporary tooth with Omnivac. After 5 months, it is pretty well healed, and a simple secondary surgery was done, and prosthesis is delivered. The crown position was adjusted a little bit, but overall, compared to the initial situation, it is restored pretty well. What I emphasize is that crown's cervical contour is improved compared to pre-op. Even though the perio is not very good, the good results can be achieved. I just talked about a single tooth case, but the dentist who raised the issue may be talking about a single tooth or two teeth case. So if it involves two teeth, another approach can be considered or required. That was a good explanation, Dr. Yang. I heard a similar story from Dr. Yang before, so I tried it. Some famous European speakers talk about this. Implant is placed and submerged. After bone graft, over it, connective tissue graft is done. Clinically, what I experience is that when I do the connective tissue graft like that on Korean patients, they tend to have more morbidity and complain more. So recently I tend to avoid to do the connective tissue graft, but like the case presented by Dr. Yang, if we use the granulation tissue when perio is not very good, that's a good idea, a very good tip. But this is just one clinical case. In principle, we need to make tissue thicker. That's very important. So from that perspective, CT graft has definite benefit compared to the initial status. Connective tissue thickness is not increased very much over 5 months. If the tissue is thicker, that's much more favorable. So the gurus have established the protocol or principle. That's why that's recommended. But as Dr. Kim said, following the protocol is not easy to do. And in Korean patients, the connective tissue is rather thin, so it is very challenging. So if you look at my case, please consider it as one of the options. Do not regard it as something that you must follow. So Dr. Yang presented a case for us. Dr. Son Young-hee, do you have anything to add? So there's the perio problem, and it is a case to extract the tooth. That's why Dr. Yang presented that case to us, I believe. I prepared a case for upper anterior. I always emphasize this in seminars and lectures. Initial drilling is 90% of the work. In other words, the three-dimensional positioning of an implant determines the prognosis of a treatment. Initial drilling is the most important part. As you can see, the initial drilling is very important. In most cases, initial drill should enter the palatal slope of a root. If the drilling is not done properly, the implant will be gradually pushed to the labial side and the drilling as well. So after final drilling, the apex should remain intact. That's the thing you need to be very careful about. The distance between the implant and labial surface should be sufficient enough. That's very important. Let me show you a case highlighting this. And number 11 is fractured. It was not an extraction for perio problem. I want to show you the three-dimensional implant position. We can see there was endo treatment, but no lesion is observed. Crown root fracture is observed. After extraction, minor flap is raised. Actually, raising the flap was not necessary. It would have been better if we did not raise it. And what I confirmed here is that labial bone is okay. After flap is raised, the labial bone would go through remodeling. So final drilling is done. When drill is inserted, this looks good. Vertically, on the labial side, there is a remaining space. As many papers say, according to Elia, implant fixtures labial platform and to the outer surface should be 4 millimeters or more. So this distance should be at least 4 millimeters. Vertical, mesodistal distance and angulation are important, but most importantly, buccolingual distance is very important. After the drilling, if you see this gap, it is very well done. In this case, if the drilling was done following the incisal outline, it's a problem, and the apex is not invaded. After the placement, there's a sufficient gap on the labial side. So that's the vertical position you need to aim for. for ideal positioning. Secondly, in terms of the vertical positioning, according to Homlai Wang's paper, for vertical positioning of an implant, the reference is 3 millimeters below CJ of an adjacent tooth. If the adjacent teeth have a bone resorption, then the situation is different, but when gingiva is healthy, we can use Homlai Wang's criteria. In any case, the gap should be filled. There are many who do not agree with me, but I did the gap filling. In this case, the cervical side dual zone concept is used. Graft material with a collagen is used with a two-stage approach, post-op CT and the standard view. On this CT, the labial bone remains. After the treatment, everybody is surprised. In this patient, immediate provisional is not used here, so I used only wire and it is attached with resin. 3 or 4 months later, prosthesis is delivered. The prosthesis is completed with the zirconia link abutment. At the time of prosthesis delivery on the CT, 3 or 4 months later, labial bone is being remodeled. So I want to say to the dentist that we need to be very careful in positioning the implant. Graft material is important. If you are to do graft, allograft, or graft material that would remodel more than others should be avoided. If possible, we need to use xenograft or synthetic bone that would remodel less. That's all. So we talked about various approaches. Regarding the first case, do you have anything else? It occurred to me while looking at Dr. Son's case. So what I want to say is that if you look at someone else's cases, drilling palatally looks easy and it looks very simple. But we say the drilling is pretty challenging especially to the beginners. On the diagram, looks like you used the initial drill with the side cutting function, as you said before. For the gap filling, less remodeling material. I use bovine bone a lot, and I also use the alloplastic, but xenogenic bone seems better in maintaining the space. So that's the way to do the grafting. I agree. In my case, from a different perspective, I want to say that whether you will raise a flap or not, or placement positions, Dr. Son talked about the CJ of an adjacent tooth. In this case, if you raise a flap and look at CJ, I believe there is a bone below 3 or 4 millimeters of the adjacent bone. Then where should we place? In this case, I believe this is a very challenging case. Periodontally, where do we need to position the cervical margin of the definitive prosthesis? There's a cervical abrasion, recession, and elongation. It looks a very difficult case. Where the margin will be placed is very challenging. Number 11 and 23, the bone in the mesial and distal side also need to be considered. This is a single case, so it was a different case. If we are to do a single case, this position should be maintained with augmentation, or if things are not good, we can go below, but the current margin will be the reference For the placement, the positioning, we are talking about the same thing. Connective tissue attachment remaining from CJ, which is 1 millimeter. So it's 4 millimeters from the free gingival margin. So what Dr. Son said, actually we are talking about the same thing, but the reference is different. When we don't raise a flap 4 millimeters from the gingival margin, or at least 3 millimeters. Considering recession, 4 millimeters would be safer. So that needs to be considered as a kind of a tip. Thank you very much for good explanations. So in summary, most importantly, positioning is very important for immediate placement. Granulation tissue can be used. I heard about it for the first time. I think that will be very helpful. Let's go to the second case. The second case, a 29-year-old male patient. The chief complaint is bridge fracture for incisors. Bridge fracture occurred. Implants are planned to be placed after extraction at 12 and 22. In this case, how much bone graft should be done? Clinically, teeth are fractured and the bridge has fallen out. On the X-ray, a nerve treatment has been made. So we are looking at this case. What do you think? Let me begin. So what I see here is that in the upper anterior region, it looks like one of the incisors has been missing from before, and the rest of the three and the treatment that has been done and the bridge is delivered, and because of the decay, the bridge has been fractured. Number 12 and 22, in the two lateral incisors, 2 implants are planned to be placed. If it were me, extraction would be more difficult than placing implants. In this case, a traumatic extraction is very critical. The teeth has received nerve treatment, so the secondary decay has occurred. Therefore, careful extraction is very important. As to the tip for the extraction, in the quadrant 1 for 11 and 12, in that case, getting the fulcrum would be difficult after removing all the brittle tooth material. When I do the luxation, I don't pull out just one. I try to luxate both of them together using an elevator between 11 and 12. So to extract number 11, you get the fulcrum from number 22 tooth, and to extract lateral incisor, you get the fulcrum from the central incisor. So extraction is very challenging because of difficulty of getting the fulcrum. So you try to extract the two of them together. When a root is fractured, odontectomy, the tooth should be cut to be pulled out. The labial bone is very important. To preserve the labial bone, you need to cut a tooth on the sagittal plane from anterior to posterior to remove the root from the side. So extraction is very hard. Professor Yang, what do you think? Let's go to the previous slide. As you can see, so the treatment plan by the dentist who raised this issue is to extract the 3 teeth and to place implant at 12 and 22 with the bridge type prosthesis. Whether it is immediate or delayed, as you can see, the buccal contour after extraction, typically the contour collapses at 12 or 22 when implants are placed. At number 11, the contour will surely collapse. For that, how we are going to do prosthesis, we need to consider that. In terms of the contour, we need to do something. Contour GBR is not a bad option. So as Dr. Kim talked about extraction a lot, not only that, on top of the implant placing area, we need to consider the adjacent situation as well. Looking at the picture, I thought the same thing as Dr. Yang. After extraction, if we knew what it was like before extraction, like a biotop, it would be helpful for the planning. Now, we don't have the information. I believe the dentist who raised this issue wanted to know whether we should raise the flap or not. I believe that is the point of the question, and the question was phrased rather indirectly. The flap is raised, and so should I raise a flap and place implant and do GBR, or can I just extract teeth and place the implants? That is the question. Personally, extraction is challenging, and so does the placement of implants, and the prognosis is not very good, and I need to do GBR very actively. So we discussed about this case. Dr. Son, you have brought a similar case. Would you explain that, please? So I brought a case. In this patient, there was a fracture on one side of a bridge. So number 11, 12, and 13 are missing. Implants are planned to be placed at 11 and 13. At 13, extraction will be done for placing an implant on the CT. Number 13 looks like there's no labial bone. I want to point this out when it comes to CBCT. There's no labial bone visible here, but actually you will find the labial bone if you go in there. At number 12, the ridge is quite severely resorbed. I raised the flap, so it looks like this. Mostly upper anterior looks like this. Today we are not going to talk about the healed ridge, but this is about immediate placement. Implants are placed and perforations are made. In most of the upper anterior cases, I do it like this. Overgrafting is the basic approach based on my 100% my own experience, especially in the upper anterior region. More remodeling occurs than we expect, so we need to get prepared for that. So I do excessive augmentation, but the suture is rather simple compared to the excessive surgery. And I use bone tech to fix the membrane. Sausage technique is used. I said excessive augmentation is made, but on the CT, it's almost embarrassing. It collapses quite a lot. It is very well healed, and prostheses are delivered. So outside the socket, when bone grafting is done, when do we do that? As I said in the previous case, from the outer surface of the fixture to the outer surface of the labial bone should be, it is not my idea, but it is based on papers, it should be more than 4 millimeters. Otherwise, internal and outer socket grafts should be done based on evidence. Therefore, after placing the implants, if necessary, based on that evidence, outer augmentation should be done for better predictability. So I prepared a case like this. I have a similar case. In this case, after extraction, we can infer what will happen based on what Dr. Son said. In Dr. Son's case, after extraction, in the anterior region, we can see the resorption. So excessive GBR was done. Despite that, If you look at the prosthesis, on the pontic area, it collapsed. That's a very general case. Despite excessive GBR, later, as you said before, a lot of remodeling occurs by lip force or speech. That would be the influencing factors, especially in the upper anterior region. There is genetically determined proportion too in terms of the thickness. If we consider them, as you said before, excessive GBR is okay, but Dr. Son did it very easily. He did the flap adaptation quite easily. If you actually do it, it can be very challenging. So you need to do as much as you can do. Thank you. Dr. Kim Kyung-won, do you have anything to add? I agree with my colleague doctors here. In the anterior region, we do excessive GBR on the labial side, and we can see it collapses quite a lot. And during follow-up, as Dr. Son talked about cone beam CT, I agree with you. In general, when doctors ask, there is a canine root there, but labial bone is not visible, and many people think there's no bone. However, actually, you will be able to find labial bone, albeit thin one. In most cases, I determine the existence of the labial bone by looking at sagittal or coronal section of an adjacent tooth on CT. So sometimes residual bone is there but not visible on CT. So I believe more aggressive GBR needs to be done in this case. In the past, I used to use allograft or autogenous bone, but now I use sandwich graft or layered graft. I prefer layered graft. Near the host bone, allograft or autogenous bone is used, which remodels faster, but in the outer area, xenograft or bovine bone, which has less remodeling potential, is used to maintain the space. Then I believe we will get better outcome. I believe the beginners are concerned about suturing, flap adaptation, or how to suture. Do you have any tip or ideas for them? It is important to do it tension-free. I don't know, but today I bring up journals quite often. Vertical releasing incision and periosteal releasing incision. There are two of them for the flap. Of the two, they say periosteal releasing incision is better. When you use them together, you can get the most volume of flap advancement. So please use both of them to get a tension-free outcome. It sounds like a textbook answer, but that's what I want to say. I totally agree with you. As Dr. Chung said, I receive that question frequently. How do I need to do suturing to prevent wound opening later? So my first answer is, rather than suturing, tension-free. How you can release the flap, that's more important. The periosteal release incision should be made tension-free, but I know people get worried about that because incision there may result in bleeding. So you get nervous in doing so, resulting in tension. And if you pull the flap with tension, the closure would not be achieved properly. Do the suturing just with the idea of approximation to make it tension-free. Thank you. We had a very good discussion about the cases, and tension-free suture is very important. As written in a textbook, we talked about immediate placement in the anterior region with the 3 guests. I thank the dentist who sent the problem to us. I hope the discussion has been helpful to you. Thank you very much. I am Dr. Jung Young-eun, and I'll see you in 2 weeks. Thank you. Thank you very much.